antimicrobial agents, and antimicrobial susceptibility testing. So antimicrobial susceptibility testing can also be called MIC, which is minimal inhibitory concentration. This is the lowest concentration of an antimicrobial agent, or an AMA, that inhibits visible growth of an organism. This is used to determine the effectiveness of a drug against a particular microorganism. Bacteriostatic, these are agents that inhibit the growth of bacteria but do not kill them. They rely on the immune system to clear the infection. Bactericidal are agents that kill the bacteria, and these are important in serious infections where killing is necessary. Then you have the MBC, or the minimal bactericidal concentration. This is the lowest concentration of an antimicrobial agent that prevents growth or kills 99.9% of the original bacterial inoculum. This helps differentiate between bacteriostatic and bactericidal activity. For serum bactericidal levels, by definition, so it's the measure of the activity of a patient's serum against a pathogen. The lowest dilution of a patient's serum that kills a standard inoculum of the organism, also known as the Schlichter test. The patient's serum contains antimicrobial agents. For drug interactions in antimicrobial therapy, you have synergism. That is the combination of two or more antimicrobial agents that provide enhanced antimicrobial activity against the pathogen compared to the individual agents alone. Then you have antagonism. This is where one drug reduces the activity of a concurrently administered second drug, leading to a decrease in effectiveness. Penicillins have a characteristic structure that's made up of three key components. First is the thiazolidine ring. This is a sulfur-containing 5-membered ring that forms part of the penicillin core structure. It contributes to the overall structure's ability to interact with bacterial cell walls. Then you have the beta-lactam ring. This is a 4-membered cyclic structure which contains a carbonyl group, which is crucial for the antibiotic's mechanism of action. It interferes with bacterial cell wall synthesis by binding to the enzymes involved in the final steps of peptidoglycan cross-linking in a bacterial cell wall. Then you have the acylside ring, and this is the variable part of the penicillin molecule, which determines the specific properties of the antibiotic, such as its spectrum of activity and resistance to certain bacterial enzymes. Penicillins act primarily by inhibiting bacterial cell wall synthesis, which is a mechanism shared by all beta-lactam antibiotics. Your next group is the cephalosporins. The cephalosporins are similar to the penicillins, as in they both have a beta-lactam ring. Cephalosporins are categorized as our second or third generation drugs, and that depends on the alteration of the R1 and the R2 side chains. The first generation is the most active against staph and streps. For example, cefalozolin had been used for prophylaxis prior to surgery, but that's not used much anymore due to antimicrobial stewardship, which was to kind of help reduce the unnecessary use of drugs. And then a second generation cephalosporin works well against Haemophilus and Moraxella, especially if they're causing respiratory infections. And then you have your third generation cephalosporins, which are targeted towards organisms that cause nosocomial or hospital-acquired infections, and if you have a multi-drug resistant gram-negative bacteria as well. The third generation cephalosporins may work better, such as ceftriaxone is an example. It treats patients with meningitis. It can also treat infections due to E. coli, Klebsiella pneumonia, Serratia, Pseudomonas aeruginosa, is also active against Haemophilus influenza. Ceftriaxone can be used to treat Neisseria gonorrhea as well. They used to always give penicillin for that, and now they start to give cephalosporins for those that are penicillin resistant. The next category of antimicrobials are the macrolides. So an example of this would be your erythromycin. Macrolides are a group of antibiotics that share a macrocyclic lactone ring structure, which are large ring-shaped compounds made up of 14, 15, or 16 members, and it includes a lactone or ester functional group. This macrocyclic ring structure is crucial to the antibiotic's activity and allows it to interact with bacterial ribosomes. Their mechanism of action is to inhibit bacterial protein synthesis. Erythromycin works by inhibiting bacterial protein synthesis, specifically by binding to the 50S ribosomal subunit of bacterial ribosomes. And then we have tetracyclines. These are plasmid-mediated resistance is common. Resistance to tetracyclines is common, and the ability to transfer this resistance between bacteria means that multi-drug resistant strains can spread easily. These are active against gram-positive and gram-negative, such as Mycoplasma, Rickettsia, Chlamydia, Mycobacteria, and Protozoa. Again, your tetracyclines inhibit bacterial protein synthesis, which is critical for bacterial growth and replication. The chloramphenicol group is oftentimes considered a broad-spectrum antibiotic. Sometimes practitioners won't order a culture or don't want to wait for the culture to be done before the results are out or available. So they will get started with an antimicrobial agent. So a lot of times they'll go with a broad spectrum just because they don't know what's causing the infection. These are active against both gram-positive and gram-negative. However, chloramphenicals may cause aplastic anemia. Chloramphenicol is often used to treat typhoid fever, and chloramphenicol will work by inhibiting bacterial protein synthesis, which again is critical for bacterial growth and replication. Aminoglycosides. So this is an amino sugar with a glycosidic linkage to an aminocyclityl ring. This specific structure is critical for the drug's interaction with bacterial ribosomes and its overall antimicrobial activity. So examples are streptomycin, gentamicin, tobramycin, and these are used to treat enterococcal and gram-negative infections. Gentamicin and tobramycin will require peaks and troughs since they have a very narrow therapeutic window. So they can be subtherapeutic, but they can also very quickly turn to that toxic level as well. So again, if you think back to when you're doing blood draws for peaks and troughs, you got to think about your therapeutic drug monitoring, back in your chemistry days when you were learning about that as well. Aminoglycosides are oftentimes used in combination with other drugs, again, that are synergistic. Mycobacterium. So these are acid-fast bacillus. Oftentimes you'll have a mycobacterium that is multi-drug resistant. So examples of drugs that are oftentimes given in combination to treat Mycobacterium tuberculosis or Mycobacterium avium complex with isoniazid or rifampin. These three drugs are typically given together in the initial phase of treatment, often for the first 2 months. The goal is to rapidly reduce the bacterial load to prevent transmission and to start the healing process. If the bacteria are resistant to one or more of the drugs, additional drugs may be added. So mechanisms of action, the isoniazid inhibits mycolic acid synthesis, rifampin inhibits the RNA polymerase, and pyrazimide disrupts cell wall synthesis. These combined actions work to reduce bacterial load and promote bacterial death. Bacterial resistance to any antimicrobial is either intrinsic, so it's inherent, or acquired. Mechanisms include chromosomal mutations, the development of plasmids or transponsons. In the biochemical mechanisms, there can be a modification of the target site of the antimicrobial. We can have enzymatic inactivation of the antimicrobial so that the production of the penicillinase, so an enzyme that activates penicillin or the beta-lactamase. So again, an enzyme that inactivates the beta-lactam ring, basically, is what that boils down to. Mechanisms could also be a decrease in membrane permeability, so the antimicrobial is not able to enter into the cell, or any of those combination of any of those above. There are certain organisms that if you identify them and determine that they are clinically significant, that you always have to perform a beta-lactamase test on. So again, what we're detecting is the production of an enzyme that converts active to inactive drug. So beta-lactamase will hydrolyze the beta-lactam ring of the beta-lactam antimicrobial agent, and the beta-lactamase production is plasmid or chromosomal mediated. Almost all gram-negatives will produce a beta-lactamase. So to perform antimicrobial susceptibility testing, the former way of doing this would have been a Kirby-Bauer disc. So now we're starting to use a large Mueller-Hinton plate and then dropping discs individually on them. For the Kirby-Bauer, we're going to measure the zone sizes and the number of millimeters of how large that zone is. 10 is generally going to correlate to susceptible, but you will have to look at the manufacturer's recommendations. In a microscan, which is probably what most microbiology labs have now, in a microscan panel, you're going to look for the minimum amount of drug that will inhibit visible growth of the bacteria in that well. So that's why it's called a minimal inhibitory concentration. So let's shorten it down to an MIC. So versus the Kirby-Bauer, you can correlate MICs and they can be matched to zone sizes. So do keep in mind that Kirby-Bauer's and the MIC are inversely proportional. With the Kirby-Bauer, you're going to take 3 to 5 colonies of an isolated organism, and you're going to add it to a Mueller-Hinton broth. You're going to incubate it for 2 to 5 hours, and then from that, you're going to set up a 0.5 McFarland standard, and then you're going to use that 0.5 McFarland standard to inoculate the plates. These plates are large, so if you think of your normal agar plate, it's about 3 times that size. So it's pretty large. When you see it, you kind of are surprised actually how large it is. So once you get that 0.5 McFarland standard prepared from your known organism, you're going to use a cotton swab to streak the Mueller-Hinton plate. So you're going to turn the plate actually 3 times, and what we want basically is a total lawn or a total coverage on that plate of growth. So you want the whole plate to have growth on it. Within 15 minutes of inoculating the plate, you need to drop your disc. So these are actually, there are actually devices that may hold up to 10 to 12 different antimicrobial discs. And what you do is you press the plunger of that into the agar, and then all discs are dispensed over the top of your Mueller-Hinton plate. You'll invert your plate and for at least 16 to 18 hours in the incubator. And then when you get those out, you're going to come back and you're going to get out your ruler. And then you're going to measure those inhibitory zones from the underneath part of your plate. Again, you'll have a guide from your manufacturer for the interpretation if they are resistant or not. So we think it's tobramycin with the zone size correlates with it being susceptible. You'll look at it, is it intermediate or is it resistant? And then that's how we would actually report that out. Again, follow your place's SOPs. For the inoculum preparation, you're going to use 3 to 5 bacterial colonies suspended in 4 to 5 milliliters of Mueller-Hinton broth to achieve a 0.5 McFarland standard turbidity. You're going to dilute this inoculum as required for the test system. For the inoculation, pour the inoculum into the reservoir. Use a multi-prong inoculator or automated system like a Rinoc to inoculate the antimicrobial panel wells. For the incubation, you're going to incubate the panels at 35 degrees Celsius and stack no more than 5 plates. For incubation time, it's going to sit for about 16 to 20 hours. For reading results, you're going to remove the excess moisture from the bottom of the plate before reading. If there is growth in the growth well and no growth in the control well, you can determine the MIC by biochemical reactions. You're going to report the MIC as the lowest concentration that inhibits growth, and you're going to interpret results as susceptible, or S, intermediate as I, or resistant as R. If you're in my class, here is a video on how to do that. For factors that can affect the AST results, so the inoculum density, this is the most important variable in AST. If inoculum is too light, it may result in false susceptibility. If inoculum is too heavy, it may result in false resistance. When using direct inoculum, colonies should be less than 24 hours old, as the older colonies may cause false susceptibility. For the composition of the test media, so the pH should be maintained between 7.2 and 7.4. A decreased pH can decrease activity of the aminoglycosides, which can cause erythromycin to appear falsely resistant. An increased pH can increase activity of the tetracycline, which may cause false susceptibility. So that's the opposite effect on some other antibiotics. Some factors that can affect the AST results continuing. So the agar depth should be 3 to 5 millimeters. If it's a thicker agar, we can have a smaller inhibition zone, which can lead to a false resistance. If we have thinner agar, we can go to a larger inhibition zone, which can lead to a false susceptibility. Temperature should be at 35 degrees Celsius. A decreased temperature could result in slower bacterial growth, slower antimicrobial diffusion, and larger inhibition zones, which could lead to false susceptibility. Stacking of panels, so when more than 5 panels are stacked, it can cause results to appear more susceptible. For testing problematic and fastidious bacteria, so we have methicillin-resistant Staphylococcus aureus, or MRSA. So a Staphylococcus aureus shows resistance to oxacillin or other penicillinase-resistant penicillins. Consider it resistant to the entire group of beta-lactam antibiotics. For the Enterococcus species, treatment for endocarditis includes a cell wall active agent like ampicillin or penicillin combined with an aminoglycoside, which is usually gentamicin. Ampicillin or penicillin is preferred unless the patient is allergic to penicillin. And then we have Enterococcus faecium, which actually shows an increased resistance to vancomycin. Haemophilus influenza, so 20 to 50% will show ampicillin resistance. We're going to perform a beta-lactamase testing, and we're going to treat with a third-generation cephalosporin. For Neisseria gonorrhea, so penicillin resistance is becoming more common, so the drug of choice is actually ceftriaxone, And then we have Streptococcus pneumoniae. The drug of choice for this is penicillin. For beta-lactamase testing for Haemophilus influenza, so if isolate is positive, we're going to have resistant to amoxicillin, ampicillin, and penicillin. If the isolate is negative, we may be susceptible or resistant. We're going to use conventional antimicrobial susceptibility testing to detect non-beta-lactamase mediated resistance. For the methods, we're going to do a visual observation of hydrolysis and chromogenic reactions, and the most common method is going to be the chromogenic cephalosporin. Testing for bactericidal activity, so laboratory tests that measures the ability of an antimicrobial agent to kill bacteria. The purpose is to determine the lowest concentration of the drug required to kill a bacterial population in vitro. For serum bactericidal test, the purpose is to evaluate the bactericidal activity of antibiotics present in the patient's serum. Example would be the Schlichter test, and it measures the ability of penicillin in serum to kill bacteria causing endocarditis.